Good afternoon, everyone. Welcome to Patient Advocates Transforming Healthcare, PATH, Tuesday Table Talk. My name is Hala Dura. I'm a patient family engagement consultant and the founder of PATH. I'm really excited for our guest today who's joining us to discuss the topic, dignity, respect, and equity in healthcare. Dr. Ronald Wyatt, thank you for joining us. Dr. Ronald Wyatt joined MCIC Vermont in January 2020 as the Vice President and Patient Safety Officer. Prior to joining MCIC Vermont, Dr. Wyatt was formerly Chief Quality and Patient Safety Officer at Cook County Health. He also served as Chief of Patient Safety and Quality for the Hamad Medical Corporation in Doha, Qatar. Dr. Wyatt was the first patient safety officer at the Joint Commission and served as the medical director of the Patient Safety Analysis Center for the U.S. Defense Health Agency, formerly the Department of Defense Military Health System. Dr. Wyatt is a member of the American College of Graduate Medical Education, Clinical Learning Environment Review Committee, as well as faculty on the ACGME Disparity Collaborative. He chairs the IHI Equity Advisory Group and is core faculty on the IHI Pursuing Equity Initiative. Dr. Wyatt is a graduate of the University of Alabama Birmingham School of Medicine and served as chief resident in internal medicine at St. Louis University School of Medicine. He earned the Master's Executive Program in Health Administration degree from the University of Alabama Birmingham School of Health Professions. He also was a 2009-2010 Merck Fellow at IHI. And we are so pleased that Dr. Wyatt can join us today for this topic around dignity, respect, and equity in healthcare. I know that this has really been top of mind, particularly in the last several months as we deal with the pandemic, as well as our elevated national conversation around racial injustice, structural racism, equity, and when we look at healthcare, particularly health equity, disparities, and social determinants of health. And so I knew that I wanted at least one talk that we could have Dr. Wyatt with us to really share the depth and breadth of his experience and knowledge in this area. And when we first spoke, what really struck me is we didn't start the conversation around what's the latest research, what's the latest data, what are we learning as we go through this pandemic and as we have this, elevated conversation around topics around equity. We shared stories with one another. And that to me is where this all begins, because inevitably this is not about numbers. This is not about all of the quotes. It's really about the person behind those words and how that person feels, how that experience made them feel. And when they go back home, how they share that with their family, their loved ones, their communities. And we know that many of those affected by COVID-19 have been communities of color, minority communities, and marginalized communities. And as we continue to have conversations around equity and disparities and social determinants of health, we really cannot forget this impact upon individuals and their families and their communities when we're talking about how did that make you feel? How did that experience shape your vision of how you should have been treated or how you expected to be treated in the medical setting? How did that impact you in terms of you wanting to return to that setting? And in many times we know that trauma, that pain, that lack of feeling respected or having that dignity is something that may make others not want to return to the medical setting or seek the treatment they may need. And even in situations where they don't have that choice, going home with that pain and trauma most certainly affects their possible recovery, and the impact that it may have on them will last a lifetime. So that's kind of where I'd like to start today's conversation, Dr. Wyatt, around the stories you shared with me, and particularly one that hits very close to home with you. And then I hope we can go from there.
Sure. So thank you so much for inviting me to share, Hala. It's really an honor to be with you and to share all of what you just described, which I think wraps itself up in one story that I'll share. And a few months ago, my brother was diagnosed with myeloma, stage 3 myeloma, and began treatment for myeloma. Now, a bit about my brother: he is a couple years older than I am, has a master's degree. He works in a supervisory position with a big government agency in the Northern Virginia, DC area. So had never been in the hospital as a patient overnight in his entire life. And we grew up in the segregated South. So as a kid, we went to the general practitioner and we could never get an appointment. And the waiting rooms were segregated by whites only and blacks only. So I got a call from my sister-in-law saying that he was in the intensive care unit. And I checked to see what was happening. Turns out he was admitted with septic shock. He was in acute kidney failure, and they thought was having a reaction to one of his medications. By now he was on steroids, he was on a monoclonal antibody, he was being prepared for a bone marrow transplant, and was on several other medications. I contacted the hospital because my sister-in-law could not get into the facility to visit with him because of COVID. And she's a layperson, so really doesn't understand a lot of the jargon involved with medical care. So I contacted the organization, asked would the physician in charge give me a call. He called me, and I knew about the kidney failure and his overall condition. I knew he was on IV medications to keep his blood pressure up. And I knew that they had told my sister-in-law that he might need temporary kidney dialysis. So I asked, one of the first questions I asked the physician was, what's the status of his kidneys? What is his renal function? And he said, well, it's improved. And I said, well, could you please share with me the number? It's called a creatinine that measures your kidney function. And when he told me the number, I was a bit confused. I said, well, the nurse gave me a number that it was yesterday. It was 2.8. But now it's 3.0. So please explain to me how that's an improvement. And he kind of began to stumble around as he stumbled through a lot of the questions that I asked that were not necessarily complex. They were things that he should be able to share. You know, questions about what was going to happen next. Was he going to see a nutritionist? What were they going to do about coordination of care between him and the specialist and his family? And I wasn't getting clear answers. The next day I talked to a nurse practitioner who was a hospitalist nurse practitioner in the ICU. And the fact is she was able to give me better information than a physician could give. And she gave it to me in a more human way. Some of the questions she couldn't answer. A couple days later, my sister-in-law called and said, well, he went to the floor and he's going to be sent home, which just astounded me. And I said, well, have they done these things? Nutrition, home care, coordinated care. Have they instructed you on what you need to do once he gets home? No. So then I talked to her on the day he went home, and she said, and I'll pause again and say, my brother is a very dignified person. He is almost a perfectionist with just his appearance and how he presents himself. And she said, I went to pick him up, and when he saw me, he broke down in tears because she said he was filthy, that he had not even gotten a sponge bath in the 4 days that he was inpatient at this facility. And they still did not give the instructions and the interactions that you would expect a family and a patient to have. And he said to her, and he later shared this with me, when he saw her in his tears, he said, the way they treated me, I might as well be dead. And that gets back to something you said about what happens next when you take a person's dignity from them and you don't show people compassion and respect that they should have. So I talked with him about the experience. He shared the same thing with me. And he said, I can't complain about the care I received medically. But what I'll say about it is they treated me like I was, and these are his words, they treated me as if I were a checklist. And they would go down the checklist every day. And he said, I would lie there and I would wonder, do they see me? Do they see me? As opposed to going through a checklist. And he said, so I felt like if I were dead, it wouldn't matter to them because they've completed their checklist. And he said, so I might as well be dead. He said, he said, I never want to come back to this hospital. I never want to engage with this hospital again. Subsequent to that, he went to see his dentist a few weeks later, who there in Northern Virginia, Asian female dentist who had went to the same facility for maternity care. And she almost died. She had postpartum bleeding and was not believed, nor was she listened to. And she said, she told him, I could have been dead. Almost the same words. And it was if they didn't care. And he said, so she said to him that, she had said that lots of her Asian friends had told her she never should have gone there and never go back. So then my brother said, so I just wonder, and he said, I really don't want to think like this, but it's all I'm left with. Did they treat me this way because I'm a Black man? That was all he had left. And he could easily see where he could have given up on following up with other appointments and complying with his medications. And then what happens? You get labeled non-compliant or non-adherent or some other label that somehow makes a system feel better. I contacted the organization, which, most people will go through the process. I contacted complaints and grievances and I got a call back a few weeks later from the chief of hospital medicine. And initially he was a bit defensive. And he started the call with me this way. He said, well, when these folks come in, and I said, okay, let's stop right there. I'm not sure what you mean by these folks. And he said, oh, I mean your brother. I said, it's not that it's my brother. You said these folks. So that's a way that you're thinking about people that shows disrespect. If you have to label people that way. I subsequently got a call from, and I asked him a series of questions about coordination of care, and he could answer very few of them. Even told me that this big, well-known system did not have a nutritionist. I said, but you sent a person home who was in acute kidney failure with no dietary instructions, no nutrition instructions. So my sister-in-law was giving him the same foods. He was consuming the same foods that he was prior to going into the hospital. And I said, he's in kidney failure. You got to have someone explaining to people what the importance of the diet is when you're in kidney failure. A few weeks later, the system level chief of hospital medicine called. These were his first words to me. He said, I wanted to call and talk about your brother. He said, I'm going to listen. And he said, because I know now that this is his words, not mine. You wrote the book, right? Now, I've never encountered him, never had a conversation with him. But somebody knew I had contributed to the patient safety chapter, at the Joint Commission. So he listened. He was apologetic. He said, I will call your brother and we'll have a conversation. And he did. And my brother, who I saw 2 days ago, said that they had a good conversation, productive conversation. He was able to share with this person how he felt, how he was made to feel, and how he feels now. And at least the system level physician leader said, we reviewed the chart carefully and we've learned a lot. And he just said, we made a lot of mistakes. And back to your point, what my brother said, he said to him was, you have to understand how I felt, how you made me feel. And he said, as almost as if this was expected, he said, I'm not angry, but you disrespected me. That's how I felt. So to your point, again, it's how systems make people feel that can lead to bad outcomes because people give up. They say, well, they internalize it. And there's a term, internalized racism, where you internalize, say, well, this is what's going to happen to me. I can't expect anything better than this. This is how I'm going to be treated. This is how I'm always treated. So what difference is it going to make if I keep my appointment, if I take my medication, if I go for another diagnostic test, because I'm confronted with a system that's not seeking to understand how I feel. And you're not showing me compassion and respect, and you pull my dignity away from me, which for some people, that's all they have left. If you take a person's dignity, it may be a person that's the only thing they're holding on to. That's the only thing that's keeping them going and keeping them alive, that I have my dignity and my self-respect. And the last thing health and healthcare should be doing is taking that away from people and seeing people as a process, as a checklist. The things that we go through is so much more than that we have to begin to think about. And in this case, I'm advocating for him and his family. And a lot of people don't have that advocate. They don't have a person who's call and say, I used to be patient safety officer at the Joint Commission. I want to talk to somebody. And I will almost bet you if that were not the case, those calls would not have come at all, or they would have come sometime out in the future. So I'll stop there for now. I get carried away.
No. I mean, first of all, thank you for sharing your family's story. I really appreciate that. And my thoughts and prayers are with your brother and his family and all of you in his, his treatment. And I do hope that as he continues through the system, that he is given the dignity and respect that everyone deserves. So there's a lot to unpack there. And I'm wondering if we could start around the checklist. And I think that's, part of healthcare's own making, right? So in that seeking to improve patient safety and looking at quality improvement, the concept of the checklists really did come into play. And of course, I'm obviously not going to sit here and say that there isn't value in those checklists. But like you said, we can't use that checklist as the process and how we take care of each patient, their family, and their caregivers. And so in your opinion and in the research you've done, how do you think we can start to go about changing that mindset in health systems around, well, if we just do everything as a checklist, we're doing it all. We're getting it all right. Yeah. And I think what COVID has shown us is, guess what? That checklist is not working at all. Right. Because we've upended the entire system at this point, right?
Right.
And so you can't even use the checklist, even if you want to.
Right. Right.
So what do you think, how can we reimagine, if we're looking at how do we start to take that down? How do we look at that checklist and say, this is not how people want to be treated? Yes, there's certain things that need to be done in order to make sure someone is receiving safe, quality care, but that you cannot treat the entire experience in that way. Right. So what would you recommend?
Right. So I'm going to recommend, and I'll try not to oversimplify it, a new checklist. And let me go back to say, we have to, in a caring profession, and taking what's happened with COVID as the kind of beacon scream for what we see, the pandemic for Black and brown people in this country began in 1492 when Columbus arrived in the New World. It began in 1619 when Africans came to the U.S., the colonies. So we have to go back and understand the historical nature of what led us to this point. And throughout history, there are those markers in time of what has led us to where we are. That includes how Black and brown people were treated during slavery, how other brown people were treated in this country for hundreds of years ago. And what has happened, the manifestation of that is a deep mistrust, distrust, and no trust for the healthcare system. So I'm going to say the first thing on that checklist has to be, how do we regain trust? Put trust on your checklist. The same populations, Black, Indigenous, and other people of color populations, LGBTQ populations, people who have been incarcerated are incarcerated. And that whole list of populations that we know suffer from inequities. We got to go back and say, we have devalued these people. We have devalued these populations. We have marginalized too many people over too long a time. We have to go back and say, how do we bring humanity back to this? How are we going to build trust without humanizing the people that come to us for care? So understanding history, making sure that we see the value in every person. Part of the value, and the reason I brought up Alabama, is part of that value is he knows what happened in Tuskegee with the Tuskegee syphilis experiments. It's part of our history. It built distrust, especially in Black men. So systems need to be sensitive to history, and that everyone needs to be valued when they come to us for care. Then it's, what do people need, right? So for too long, and this was also uncovered during COVID, communities who did not have the resources they needed. And in fact, pre-COVID, the communities and community hospitals did not have the resources they needed. So along comes a pandemic, and all of a sudden, we realize they don't have supplies, equipment, PPE, medications. They didn't have the things that they needed, right? But because they've been unequally allocated someplace else. So understand history, understand that people have a value, understand that we have to put resources where they are most needed, not based on income, insurance status, how you look, how you dress. We have to move those things aside now. So that checklist needs to include, we're going to build trust in all of our communities that we say we care about, right? We're going to show compassion. We're going to understand with humility what we need to be able to recognize and respond to. And part of that is recognizing where a person is from and all those social issues we now talk about as social terms of health. It all plays into who this person is that's coming to us for care. And then how on that checklist has to be, what does respect look like? What does humility look like? Bringing all those things to that list on everyone that comes to us. And I think over time we can build trust and move forward and provide more equitable care, not equal, but equitable care. So that if I want to be healthy, if I want to achieve the highest level of health I can, I say to a system, please don't block the way. Don't put these structures in place. Remove the policies that are built into systems that continue to perpetuate disrespect and mistrust. I'll pause.
I think, obviously, I agree with all your ideas, and I think though what's important, and I'm wondering your thoughts on this, is who is involved with creating that new list, right? Who is part of that leadership? Who is at the table? Whose voice is part of that discussion? And I think that's another area in healthcare we struggle. I mean, I'll just speak just about the little sliver of healthcare, which I wish would be so much bigger, patient-family engagement, which also in many respects is treated as a checklist, right? It's a checkbox. We did it. We talked to them, we sat with them, we have some advisors in the hospital, we're good. And when you peel back some of those layers, you realize, no, actually, right, you're not. There's room for improvement. Right. So I'm wondering, how do we also look at the who? Yeah. And really encourage leadership to begin to make space, whether that's within healthcare systems, whether that's at the levels of education and training for physicians and nurses and other healthcare professionals. Where do you see those opportunities for us to really push the who?
Yeah. So I mean, that is such an excellent point. Systems spend a lot of time on what, when, how, and why. I would say start with who. So what does that mean then? Is a system collecting valid race, ethnicity, and language data? And then do you stratify that data to understand the population being served? Are you collecting valid sexual orientation, gender identity data? And then are you stratifying that data to understand the needs of the population, the community, and what matters the most to that population, not what matters most to the system? So a lot of that then means a change in the mentality. That means that we got to come to this with a servant's attitude and be servant leaders for our community. So it's what matters to the community. That's the who. And how do you make policies and guidelines and procedures for the populations that are coming in that we want to trust us if they're not involved with the policies and the guidelines and the procedures? If you don't have a workforce that reflects the population, if you're not involved with the community that you say you're here to serve, if you don't know what's going on in the community, you have to start with all those things. Bring people to the table that have not been at the table before. And that's when we get into a discussion about institutional and structural racism. We have to be specific about it and ask the question, how is racism operating in this system? And we need to undo it. So you undo it by the first things I talked about, organize around this. You have the data. Then at a board level, work with the community to say, we want to formulate a strategy that is going to respond and understand what matters to you. And then the most important thing is to act, not just to write more policies and procedures. And to your point, oh, we have a patient family advisory council, we're all there, right? But are you acting on it? Because I always say that inaction is violent, right? To say I'm acting and I'm not is a violent act in and of itself. So organize, strategize, and act on this, and be engaged with the communities, collaborate, partner with the communities, bring the voices to the table. As they say in Hamilton, you got to be in the room where it happens, when all of this takes place. So it's because we know that the more diverse and inclusive the voices are, the more innovative and creative the system becomes. And guess what? For the finance people, it shows that if you're more diverse, if you're more inclusive, you actually make more money, because the money people are back there counting the beans, as we say. But these things, when you collaborate and partner, then everyone does better. Everyone gets better. Trust levels go up. We respect each other. We begin to, in a bi-directional way, begin to understand each other a whole lot better than we are right now. But we have to be specific, and we have to say, do we have racism that's built into our system that we need to remove? We have to talk about it. We have to be specific about it. I say to people, you need to require implicit bias training. You need to consider, what does cultural humility look like? That means we close these power distances between the people we say we serve and our system. That's another part of being a servant leader, right? That you narrow that power gap and that you listen to people and you seek to understand what people are saying. You seek to understand the experiences that people have in the communities that are right outside our door, that we ride by every day and are not engaged with. So those are some of the ideas I have. It's a new checklist that we need to think about, and how we sustain it, how we grow it, and how we maintain it and nurture it. Oh, and I'm going to say, and you asked about medical education. So this collaborative, we work with ACGME, we're working with trainees. We need more nurses and physicians of color in organizations. That 5% of the physician workforce are Black. It was about the same in 1899. That's got to change. Inside medical schools and residencies, there needs to be curricula developed around implicit bias and around understanding what institutional and structural racism is and how it operates in the system, because it just takes all of the energy out of a system. Institutional structural racism, it just, as my friend Kamara Jones says, it saps the system of all of its energy. So it's got to be put into the curriculum in medical schools, nursing schools, all professional schools, so we all begin to understand this in ways we never have before.
Yeah, agreed. I also think too, part of that is really embracing this concept of co-design and co-creation, that you have to bring the patient, family, caregiver perspective into designing that curriculum, designing that training, really being part of perhaps one day, medical school faculty, and being part of training residents and fellows. I think that too is an opportunity where you will get to hear that voice and those stories and understand the community when you do bring in other voices to the table. So I know we could talk, all day, Dr. Wyatt, and I hope we can have an opportunity to talk again soon. But unfortunately, we're at the end of our
Thank
time.
you.
But thank you so much for your insight, your reflections, all of your leadership and work in this area, as well as sharing, your personal story with us today. I most certainly appreciate that greatly. And I thank our audience today for joining us. Someone typed in the chat, a patient is so much more than a checklist. Thank you for sharing your family's story.
Thank
And
you.
so with that, I will end there. Thank you to our audience again. Thank you, Dr. Wyatt. We will not be having a table talk next week because next week is election day. So if you have not voted, please, please, please vote. There is power in your vote. So please go out and vote. And we will be back the following Tuesday. Thanks again to everyone. Dr. Wyatt, if you could just pause with me on mute for a few seconds while we close the stream. And we'll see you all in a couple weeks. Thanks.